At this point, I would like to quote the late Dr. John Niparko, the founding co-chair of our organization, who said the ACI-A brings together the people with the expertise to gather the resources to improve the education, collaboration, and focus of our community. This statement still remains the basis for the guiding principle of the ACI-A, where we continue to foster multidisciplinary collaboration to enhance cochlear implant-related research, advocacy, and awareness. In Dr. Niparko's memory, we have established a John Niparko Memorial Lecture. I would like to ask Dr. Rob Labadie to introduce this year's John Niparko lecturer. Rob is a prolific scientist, cochlear implant researcher, and currently serves as the department chair at the Medical University of South Carolina. He's also a friend of mine. Prior to this position, Dr. Labadie held several leadership positions at Vanderbilt University, where he also had the opportunity to work with René Gifford, our John Niparko Memorial Lecturer this year. At this point, thank you, Rob, for introducing René.
Thanks, Oliver. So I spent 20 years at Vanderbilt before moving to Charleston this past January, and there isn't a day go by that I don't miss my collaboration with René Gifford. We literally worked next to each other. She was right down the hall from me. And that led to so many conversations about scientific issues, graduate student projects, and maybe more importantly, the navigation of life, just getting through what we all get through. I'm not going to rehash her bio. Her bio is on the ACIA website, and it is way impressive. I will add one thing, and that's that last week, not last year, last week, she was named the inaugural Fred H. Bess Chair in Audiology at Vanderbilt University, which is awesome. So congrats, René. But I do want to share one little background story that I think some of you might not know, and it may give some motivation to why René chose the path that she chose. So René was raised by her grandparents, and her grandfather, Jim Costello, was a World War II vet. And in René's words, he was a badass. He was a paratrooper. He was shot down in 1943 in the Battle of Sicily, and he got the Purple Heart. And he healed from all of his physical wounds, but he maintained horrible tinnitus and high-frequency sensorineural hearing loss. And I wish I could bring him on stage here today and say he got a cochlear implant and life got better. But that's not how science often works. Often, it's the next generation that benefits from this, and René has helped that next generation. So instead of introducing Jim Costello, I'm going to introduce his granddaughter, a badass scientist, to talk to us about her incredible research. René? What's up? Stay up there.
Hi, everyone. I'm trying to decide if I should get the stool or not. I think I'm okay, because I'm too much of a klutz. I will fall off. Could I get the clicker?
Sorry.
Thank you. Well, it's great to be here with you all today. Thank you so much for this invitation. Here are my disclosures. Dr. Niparko, so that's why we're here today. I can't really adequately express how honored I am to be here today. It's just really, honestly, I'm without words. The purpose, of course, of this lecture is to recognize the tremendous work that Dr. Niparko did for this field, for his patients, and for all of us here. Whether or not you were familiar with his work, whether or not you knew him personally, read his books, or one of his patients, it doesn't matter. All of us here today in this room have benefited from him and his legacy. Not only was Dr. Niparko an exceptional surgeon, clinician, researcher, and advocate, he was much, much more than that. He worked tirelessly to ensure that children had access to cochlear implants as early as possible and as many that needed it as possible. We owe so much to him, and it's really just a joy to be here to provide this lectureship. So I'm going to give us a little bit of a journey from 1997 to today, which is a 25-year history, and then we're going to move toward and look in what we're going to take to get to the future. All right, evolution of cochlear implant care over the last 25 years. So 25 years ago was 1997, which really can't be possible, but it is. Many of you might not remember 1997 very well. I certainly do, because it was a big year for me. But let's kind of take a walk back in time. 1997, Bill Clinton had just started his second term as president. The Packers won the Super Bowl. The English Patient was the best picture, and of course we also had the release of Titanic and Men in Black, massive movies even to this day. No Doubt and the Spice Girls were spicing up your world on the music charts. Some amazingly best-selling books were released that year, including the first in the Harry Potter series. Dolly the sheep had just been cloned. The Marlins won the World Series, and of course the world mourned the loss of Princess Diana. Well, it was also a big year because I graduated with my master's degree in audiology that year, and if you're not sure, I'm the one on the right. And I got that opportunity at that point to start my pediatric clinical fellowship year at the Vanderbilt Bill Wilkerson Center before going back to get my PhD. So let's now move into where were we in 1997 for cochlear implants? Well, if you got a cochlear implant in 1997, Advanced Bionics had their C1.2 device with their Clarion speech processing system. The Nucleus 24 system had just completed the clinical trial and would be released officially the next year. So if you got an implant in 1997 from Cochlear, you got the original generation N22 with the Spectra processor. Med-El in Europe had approval for their Combi 40 Plus system and their CI Pro Plus processor. Now, note that all of these processing systems back then were body-worn processors. So what a stark contrast we have today with the tremendous miniaturization and the expanded technology that's available to our recipients. Current indications have broadened dramatically in those past 25 years. In 1997, adults had to have bilateral severe to profound sensory neural hearing loss with less than 40% sentence recognition. Children had to be 18 months of age or older to get a cochlear implant. And if they were old enough to participate in behavioral speech perception assessments, less than 20% word recognition, but bilateral profound loss. Today, in 2022, adults can have moderate sloping to profound sensory neural hearing loss, scoring up to 60% sentences, or 40% for those that are Medicare beneficiaries. Children can be 9 months or older, and of course, we all know we're implanting younger than that when possible. Older children can still score up to 30% word recognition. We now have EAS hybrid indications, allowing individuals with essentially normal hearing in the low frequencies, but severe to profound sensory neural hearing loss in the high frequencies to obtain this miraculous technology. And of course, as we're going to hear a lot this week, SSD, we have 2 now FDA-approved indications, and this has tremendously just kind of revolutionized the care that we can provide for that population. Now, our state of knowledge has also dramatically improved. In 1997, we were just 2 years past the second NIH consensus conference. Their overarching conclusions were that 1, cochlear implants provide significant communication benefit for most people that are postlingually deafened, but not necessarily prelingually deafened adults, which of course we know is completely not accurate. We have Lou Ferrigno here today who is telling us how important cochlear implants have been for him. Highly variable outcomes. This is going to be a resounding theme. Percutaneous cochlear implants still have value, is what the FDA said, and in fact they do for research purposes. And of course, a big need at that point was to get MRI compatibility as well as telemetry capabilities, because we didn't have that then. We couldn't even really measure electrode impedances. Today, the closest we have to the NIH consensus document would be the 2020 group of individuals from around the world that came together to put together some consensus statements about implants. Now today we know that patients can derive significant benefit, all patients. Doesn't matter, prelingually deafened, postlingually deafened, for everyone. We still see highly variable outcomes, but we're learning more and more every day about what variables are impacting those outcomes and what role we play in potentially mitigating those effects. The biggest need, of course, is still cochlear implant awareness, and we need to work together to overcome that. State of the knowledge for pediatric candidacy today. The ACI-A task force just released this great document. If you haven't read it yet, I highly recommend it. And they highlight it in, of course, this beautiful infographic that's showing that if you have a child with a PTA essentially of 70 dBHL or poorer, and or if their word recognition is 50% or poorer, and or if they're just not making adequate progress with their hearing aids, this child should be referred for a cochlear implant. And further, out of Australia, they've indicated that children who have a PTA of 65 dBHL or greater will stand a 75% chance of doing better with a cochlear implant than their bilateral hearing aids. They also indicate that children implanted under 2.5 years of age are still going to exhibit language delay on average. So, of course, we want to minimize that language delay as much as possible with earlier implantation. CI utilization in adults and children around the world really is pretty abysmal, unfortunately. This technology is so dramatic and it changes so many lives, but people aren't pursuing it for a various number of reasons. Now, the data there are a number of papers out there and a little bit kind of variability in terms of the results, but really, in terms of adult utilization, the range is anywhere from about 2 up to almost 13%. But that means that almost the majority of people who could benefit from this technology are not pursuing it. On the pediatric side, we're doing a little bit better in this country, but we're still not doing a really great job. In the US, only about 50 to 59% of children born with a bilateral severe to profound hearing loss are getting a cochlear implant. Now, to contrast that with countries such as Australia, Germany, and Sweden, the utilization rate for children is closer to 95%. So we really have a lot of work to do here. Clinical care delivery. Okay, audiologists, this one's gonna sting just a little bit, but just giving you a warning. In 1997, as I mentioned earlier, the CI-24M clinical trial had just been completed. As part of that clinical trial, the outlining protocol was 7 to 8 audiology visits in the first year following cochlear implantation. Well, how have we evolved? Well, not much. So in 2019, the AAA clinical practice guidelines outlined 6 visits for adults in the first year, 7 visits for children in the first year. Now, I am not faulting the AAA consensus committee. They did what they could with the data that are in the literature at that point. But, for example, in 2014, this paper, if you haven't read it, this is phenomenal. There's so much information there. But this was a group of individuals from 7 cochlear implant centers, 17 countries, and 5 continents. They got together and they queried all of these individuals about current practice patterns amongst these different countries and cochlear implant programs. What you're looking at here is the data with respect to the number of audiology sessions that the patient was seen in that first year following surgery. Note that about half of the sample was still performing about 7 or even more than 8 audiology visits in the first year. This is despite the tremendous evolution of technology, our knowledge, what we know about what we do to improve our patients' outcomes and get them on the fast track to optimum hearing performance. This is also completely unsustainable. We can't do this if we're going to get beyond that 2 to 13% of utilization worldwide. Now, to kind of frame this in another way, let's take a look at another kind of unsustainable business practice that we're all likely familiar with. Remember Blockbuster? This was my Friday night for many, many years. In the late 90s to early 2000s, they were on top. They were unbeatable until they were. They weren't unbeatable forever because these guys came around. And in the year 2000, Netflix actually approached Blockbuster and they said, you can buy us for $50 million. They declined. Today, in 2022, Netflix is valued at approximately $80 billion. A little different. And now today, we have all of these different streaming services, and we can watch movies, TV, anytime we want, right here on our phones. So, unfortunately, we are still operating like a blockbuster model of clinical care delivery for our cochlear implant patients with respect to audiology visits. And we really need to evolve because we don't want to dissolve. What's that going to look like? So let's put this into the terms that really I know, so from the perspective of our clinical program at Vanderbilt. If we were to apply the current clinical guidance for these visits in the first year, now we implant about 300 patients a year at Vanderbilt. Here's our adult and pediatric breakdown roughly. This would translate to about almost 1,900 visits per year for just newly implanted cochlear implant patients. And of course, that is plus our existing patients because this is a cumulative patient model, of course. Now, if we assume a full-time clinical audiologist has about 36 clinical hours per week, 48 weeks a year, of course, we all are seeing, some people are seeing 60-minute appointments, some 90, some 2 hours, so I kind of split the difference and put 90-minute appointments. The typical clinical audiologist working full-time can see 24 patients a week, or just over 1,100 patients per year. This does not include preoperative evals. So how are we going to free up our schedules so that we can bring more people into the clinics and get this technology to the people who really need it? We've got to change our approach. And I think we've identified at least one of the major bottlenecks here as to getting people in the door. It's us. What can we do? Well, what we did at Vanderbilt a few years ago, and please, I am not trying to say we're the model of this, we have a lot of room for growth as well. But in 2011, when I got to Vanderbilt, they were, and honestly, where I came from, Mayo Clinic, we were doing the same, seeing about 7 visits per year for adults and 8 visits for children. But recently, we really streamlined our protocol because we want to get people on the fast track to their maximum hearing potential as quickly as possible. And we want to free up our schedules so that we can see new patients as well as those with their complex clinical issues postoperatively. So in 2015, we cut our adult visits to 4 in the first year. In 2015, we cut our pediatric visits to 5. How did we do this? Well, we used data to drive those clinical decisions. So we built this upon our clinical protocol where we have ESRTs, or electrically evoked stapedial reflex thresholds, obtained for every single patient at the 1-month point, sometimes earlier. And yes, that also includes toddlers. We might not be successful initially, but we're going to keep on trying until we get that information. Secondly, we also now have access to Autopilot software at Vanderbilt. Many other programs here today are also using this. And this allows us to get CT imaging information to our audiology and otology team by the activation appointment so that we can use that individualized information, such as, does this person have extracochlear electrodes? What's the frequency allocation look like? Might there be some electrodes that might be better served if they were deactivated, and so forth. Well, then we looked at our clinical database, and we made sure that we only pulled people for whom we had speech recognition testing done at 1 month, 3 month, and 6 month. This was 204 adults. Now, this was including both those with pre- and postlingual onset of deafness. Here are the data. So we've got CNC, or monosyllabic word recognition, on the y-axis, plotted as a function of the different time points. And you can see each of the individual gray lines is an individual patient, and the red represents the mean and ±1 standard deviation. We see no difference in performance on average between the 3 and 6 months appointment, but both were highly significantly significant as compared to the 1 month. So we cut the 3 month. You could actually cut the 6 month if you want. It doesn't matter. You just have to cut one of those visits. Now, this doesn't mean we can't see the patients at those times. If they need to be seen, absolutely, we can do that. It's just that we're kind of trimming our schedule so that we can keep it open for those who really need to see us. Now, this streamlined protocol that we enacted was that we went from doing 161 cochlear implants in 2015 to 301 just 4 years later. So that's how dramatic this can do and can open up your clinical access. What else can we do to really open things up and allow more individuals to take advantage of this technology? We can use more of the remote programming options. We've all kind of been forced to do that during the pandemic, and it's absolutely possible, and there are plenty of published studies showing that the outcomes are no different than if the patient were right there with you in the room. We can use remote testing, such as the remote check that's available from the Cochlear system, as well as I know all of the cochlear implant systems are working on the speech recognition testing that patients can do right from their smartphone. How about self-fitting? This is something that's also going to be possible. We can also streamline our evaluations. Right now, we're probably spending a little bit too much time, and I love that time I have with my preoperative patients, and I love collecting that data, but we could probably make that appointment a little bit shorter. We could take advantage of things such as like the Cochlear Provider Network, removing redundancies from the preoperative evaluations, because why do we need to repeat an audiogram from a trusted partner? We can offer same or next day activation. I have done hundreds of these. It's not always my favorite thing to do. There's a little bit of swelling, people might be a little groggy, but these are things that are absolutely possible. We've also even enacted a program allowing for same-day preoperative eval and surgery for those that don't require prior authorization for insurance, such as Medicare patients. And for those patients that are just absolutely kind of slam dunk candidates, bilateral severe to profound sensory neural hearing loss, this is such a phenomenal opportunity for them. We can offer more individualized cochlear implant programming, really tailoring the needs of that programming, the parameters, the electrodes, the frequency allocation to really optimize that individual patient's outcomes. And all of these things, even beyond speech recognition audiometry, such as maybe the use of corticals, use of suprathreshold assessments, taking into account neurocognitive processing, all of these things, if we can employ at least a few of these, this is also going to hopefully allow us to overcome hearing healthcare disparities that we know exist due to race, ethnicity, SES, and of course the region. Most of the cochlear implant centers in this country are located in large urban areas, but the majority of people don't always live in those areas. So this would allow things to open up. Well, what else has evolved over the last 25 years? We could talk forever about the clinical care model, but there's been so much other growth. So of course, one of my favorite things to talk about is the merging technologies between cochlear implants and hearing aids. Bimodal hearing is just so well accepted now, but it's hard to believe that even in 1997, it wasn't something that was widely used. In fact, a lot of people, once they got their implant, they took off the hearing aid. But now we know we need to strengthen and completely stimulate those bilateral auditory pathways. In fact, the very first paper that even mentioned that bimodal hearing was possible was in 1992. And now today, there are over 600 refereed papers specifically discussing the benefits of bimodal hearing. And in fact, the other thing that's really improved, which has been just so exciting to see, is that many years ago, we used to have cochlear implant audiologists and hearing aid audiologists. And that divide was so great that they didn't even communicate with one another in some cases. So we had patients that have this kind of split personality, and they'd go to one person to take care of one ear and one to take care of another. And we really now need to bring that people together, get rid of the split, and we can focus on single patient, single hearing healthcare provider. But it's not just bimodal in the sense of hearing aid plus contralateral cochlear implant. We now have integrated EAS technology in all 3 FDA-approved cochlear implant systems, so we're seeing increasing rates of hearing preservation that we can then aid those patients for significant improvement in their outcomes. This particular intervention is really very near to me. And the reason is that if this didn't actually come about around the time that it did, I wouldn't even be doing cochlear implant research. It was because of EAS hybrid technology that I actually pursued a postdoctoral fellowship working with Michael Dorman. Otherwise, I would likely probably be doing psychoacoustic research with normal hearing and slightly hearing impaired populations, looking at auditory filter shapes and all of that extremely boring stuff. But we know that cochlear implants plus bilateral hearing aids offer tremendous benefit for our patients. This offers what no other hearing aid or cochlear implant combination can offer, which is access to low-frequency, fine-structure ITDs, intraoral time differences, which is so important for orienting in space and understanding speech in very complex listening environments. And we can see improvements in localization, speech recognition, reverberation, quality of life, effort. The list goes on and on and on. How many hybrid studies were published in 1997? Not a single one. No one was even talking about it then. Well, I'm sure some people were talking about it, but not at the conferences. The first paper on this topic wouldn't be published for 2 more years from the von Alberg and colleagues. Today, we have over 500 papers and probably more. It's hard to do those search terms. And as I said, all 3 of the cochlear implant systems have integrated EAS technology, and all of the electrodes available today are atraumatic enough to preserve that residual acoustic hearing. And we're seeing an increasingly prevalent population of individuals getting bilateral implants and who have bilateral hearing preservation. These patients are outstanding. They have access to low-frequency fine structure interoral time differences, as well as the interoral level difference cues that are afforded by the bilateral implantation. Now, I have 8 patients that I've seen just recently in the lab who are what we call the bi-bis. They've got the bilateral hearing aid, bilateral implants. You're looking at a hint SRT with speech at 0, noise from all around. And so, of course, in this particular measure, a lower score is better. So you're looking at a single implant alone, bilateral implant alone in the middle, and bilateral implant plus bilateral hearing aids. Now, I have, for reference purposes, you can see those horizontal lines represent the normative score for normal hearing individuals, children and adults, on this exact measure. You can see that in their bi-bi condition, there are people who are at or better than average for normal hearing performance, and many of whom are approaching that. We've never seen this before in not even only 25 years, 50 years of cochlear implant research, and it's just so exciting to be here. Don't forget about bilaterals. We take this for granted. In 1997, this was not something that was FDA approved. Insurance wasn't covering it. It was considered completely experimental. And in fact, there was, that I'm aware of, the single first bilateral cochlear implant recipient has been implanted just a year prior by Professors Helms and Mueller at the University of Würzburg. Today, it's considered standard of care. Why wouldn't we want people to hear with both ears and optimally with both of those ears? And we know the tremendous benefits afforded by bilateral implantation. Cochlear implant for single-sided deafness. There's nothing in 1997. I've got nothing to add. To 2022, it's all over the place. And how exciting is it that we now have 2 approved FDA indications from MED-EL and Cochlear. And we know the tremendous benefits, highly significant benefits, that this affords our patients to restore hearing in both ears. Now, I could talk for the next few hours on all of the tremendous things that have happened over the last 25 years. I want to highlight just a few more before we move on to the future. Of course, we've seen universal newborn hearing screening. This was not a given in 1997. We were more seeing like the high-risk screening, but this was not happening for every well baby born in the United States. We now have seen that the JCI-H has now gone from a 1-3-6, so the screening, identification, and intervention at 1 and 3-6 months, and is now recommending more of a 1-2-3 approach. We have data logging capabilities, which is amazing. There's so much research showing that if you just wear the device, that experience is going to increase your outcomes. We just didn't know. Patients would say, yeah, I wear it all day long. And then when we got data logging, we were like, oh, you're wearing it 4 hours a day. That's not all day. We have AUD programs now, and we have AUD programs that actually offer cochlear implant courses to their students. I didn't have a cochlear implant course when I was a master's student. I had a few lectures in one of my classes, and really the message was, they don't really work that well. And the problem was that the average age of implantation at the time was 5 years of age. So yeah, they weren't working as well. We kind of missed that critical window. For those who might not have a comprehensive cochlear implant education during their graduate program, we have things such as the ICIT course for professionals, audiologists, speech-language pathologists, AVT, as well as surgeons. It's a tremendous professional education network. And of course, we have the ACIA, which we didn't have then. Well, what does the future hold for us? The future is very bright, and I would love to see more things such as functional neuroimaging coming into our actual clinical practice, such as fMRI preoperatively, or FNIRS, EEG, which can be done both pre and post-op. Maybe even structural neuroimaging, such as DTI, which tells us about the white matter tracts, particularly with respect to the auditory system. Looking more at audiovisual integration, cross-modal plasticity, use of automated audiometry, which we can get from our cell phones even, and it's really accurate. Because honestly, if I don't ever do another audiogram for the rest of my life, I think I'll be okay with that. As much as I love, audiology, but really I would prefer to free up that time so I could be practicing at the top of my license. We're going to see the integration of pharmaceuticals, drug-eluting electrodes, maybe even combining cochlear implants with hearing restorative therapies. Use of oral rehab more often in adults. We're just not even really tapping into that for the adult population. Use of imaging to help guide surgery, as well as to guide our audiology programming practices. Finally, looking at the whole person, quality of life, fatigue, listening effort, cognition. These are all things that have largely been overlooked in our clinical practice. Now, the exciting thing is all of these things are already happening. It's just that most of them haven't made their way into standard clinical practice. So I look forward to seeing the next 25 years. So the future looks really bright. We can honor and learn from our past. Of course, we can celebrate the progress that we've made, which has been tremendous. And then we can get together and work to build the future that we need. Thank you, Rob, for providing that great introduction to my badass grandfather. He was amazing. That's a picture of him. He was a paratrooper. He was shot down. He describes that he did not hear anything at all for about 2 days after that happened, slowly started to get his hearing back. Now, of course, with a hearing loss like that on the lower left-hand side, back then there really wasn't much that could be done. Hearing aids didn't work very well for him, of course, back in those days. And, cochlear implants weren't even available at that point. So I remind myself of this every single day, where I came from, what my purpose is, and this is it. We can't forget that worldwide there are over 430 million people with disabling hearing loss. Now, granted, not all of them are cochlear implant candidates, but a lot of them are, and a lot of them don't have access to this today. That's why we're here. In summary, thank you so much for giving me this opportunity to provide your John Niparko lecture for 2022. It's been just a great journey thus far, and I look forward to seeing all of you at the conference. Thank you.
Thank you, Renee. Fantastic lecture. And on behalf of the American Cochlear Implant Alliance, we would like to present you with this present. It's a glass bowl that Donna told me is from Dr. Niparko's favorite shop in Vermont. So thank you again for presenting today, and we look forward to seeing you throughout the meeting. Thank you. And thank you, Rob, for the introduction. So in closing, thank you all for being here. Thank you for supporting the American Cochlear Implant Alliance. I look forward to a great conference, and hopefully we can all see you again in future conferences as well. Thank you.